Okay, all right. So let's begin. I think most likely what we'll do is most likely we'll divide this into 2 session lah. Mungkin kita buat sebab ada banyak list tu kan. We'll do probably half today, and then probably the other half we'll do we'll arrange another session lah. Probably 3 orang je lah present hari ni Boleh? Haci, terpaksa Haci lah. Tak ada sempat sebab I need to go and vaccinate and so many things. And I see you also it's a bit busy. Okay, all right, let's proceed. Tafadhal.
Can everyone see the slide?
Yes, yes.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So today we will be presenting regarding procedure presentation. So I am the first presenter. Yep. Slide bergerak. Tak bergerak. Okay. So my name is Suryana Amira binti Syaiful Azman. So I will be presenting regarding methods of urine sampling or collection. So first we have urinary catheterization. So indications for catheterization include to drain the bladder prior to, during or after surgery, or for investigations, or to accurately measure the urine output, to relieve retention of urine, or to relieve urinary incontinence. So there are contraindications including urethral trauma or acute pelvic fracture. There are also relative contraindications such as recent genitourinary surgery or known genital abnormalities such as hypospadias. So for catheterization, we would need dressing trolley, catheterization pad and drapes, sterile gloves, appropriate size catheter, sterile lubricant or xylocaine jelly syringe, sterile water to inflate the balloon, 5 ml or 10 ml syringe, specimen jar, sterile normal saline, strap tape to secure catheter to leg, drainage bag, and waterproof sheet. So for the catheter size, we need to choose based on the patient's age. For example, for a neonate weighing less than 1200 grams, we need to choose a size of 3.5 FR. Okay. So the procedure differs between a male child and a female child, but the initial steps and the final steps are not that different. Okay, so first we have to perform hand hygiene. Place the child in supine position with knees bent and hips flexed. And if there is soiling, we have to clean the genital area first with soap and water. And then we perform hand hygiene again. So open the dressing pack and prepare the equipment as needed using aseptic technique. We pour sterile normal saline onto the tray and perform aseptic hand wash and don sterile gloves. So apply sterile drapes and towel on the patient. So we start doing the catheterization. So separate the labia with one hand and expose the urethral opening. In neonates, the urethral meatus is immediately above the hymeneal pharynges. So using swabs held in forceps in the other hand, clean the labial folds and the urethral opening and move the swab from above the urethral opening down towards the rectum. So discard each swab after each urethral stroke into the waste bag or any designated waste area. So, and then we lubricate the catheter. So insert the catheter into the urethral opening upward at approximately 30-degree angle until urine begins to flow. So, and then we inflate the balloon slowly using sterile water to the volume recommended on the catheter. Check if the child feels any pain. If there is pain, it could indicate that the catheter is not in the bladder. So deflate the balloon and insert the catheter further into the bladder. Always ensure urine is flowing before inflating the balloon. So withdraw the catheter slightly until resistance is felt and attach the catheter to the drainage system. So after we are done, remove gloves and perform hand hygiene. Secure the catheter to the thigh with either a catheter securement device or tape. And then clean the trolley and dispose of used articles into yellow biohazard bag. And then perform hand hygiene. So that's for a female child. For a male child, so the initial steps are just similar. And when we are inserting the catheter, leave the penis and retract the foreskin if non-circumcised, and do not force the foreskin back, especially infants. A sterile gauze swab can be used to hold the penis. So using our other hand, clean the urethra opening with swabs held in forceps, and we use a circular motion from the urethra opening to the base of the penis. Discard the swab each time into waste bag or designated waste area. For boys older than 3 years, insert silocaine gel into the urethra. Gently hold the urethra opening closed and wait 2 to 3 minutes to give the gel time to work. For infants, we can apply sterile lubricant to catheter before inserting the catheter. When inserting the catheter, hold the penis with slight upward tension and perpendicular to the child's body, and then we insert the catheter. So when the first sphincter is reached, around the level of the pelvic floor muscles, gently bring the penis down to face the child's toes and apply constant gentle pressure. If resistance is felt, the following strategies should be considered, such as ask the child to take a deep breath, ask the child to cough or bear down, or gently rotate the catheter. Okay. So next we have suprapubic aspiration. So indications include labial adhesions, labial edema, unretractable foreskin, unsuccessful urinary catheterization, urethral or infrarectal surgery. Contraindications include genitourinary abnormalities, infection of the abdominal walls, clinically significant bleeding disorders, or massive organomegaly. Equipments needed are anesthetics, adhesive bandage, 23 or 25 gauge, 1.5-inch needle, 2 sterile 5 ml syringes, sterile gloves, sterile grape, antiseptic solution with sterile gauze, sterile specimen container, and ultrasound. So use portable ultrasonography to assess bladder volume before and during the procedure to increase the success rate. So the patient is restrained in supine and front leg position. This position permits adequate stabilization of the pelvic. So wash hand and wear sterile gloves and clean the skin from the umbilicus to the pubic symphysis. Drape the area to avoid contamination. Place sterile cover on the ultrasound probe and apply ultrasound gel on the abdomen around 1 to 2 centimeters above the pubic symphysis. Use 1.5-inch needle for the aspiration, and with the help of real-time ultrasound guidance, hold the probe on the abdomen, insert the needle midline and just inferior to the edge of the probe at an angle that is perpendicular to the abdominal wall. Okay, so that's it for suprapubic aspiration. So next we have urine bag, sampling to urine bag collection. So for this, equipments needed are wipes, urine collection bag, plastic cup or specimen jar, and also plastic bag. So the procedure include, first we have to clean the area. So more details on how to clean the area, you can read the diagram. And then uh, for the urine collection bag, we first remove the protective backing from the bottom half of the adhesive patch of the urine bag. So first only remove the bottom half. And then we spread the child's hip and stretch out the skin folds in the groin. And then we place the bottom part of the adhesive bag on the skin carefully and accordingly. So press the adhesive smoothly and firmly in place. And after that, we remove the upper part of the adhesive patch. So now we can put on a clean diaper and we can collect the specimen later. Okay, so clean catch. So for clean catch, first we must have the sample container ready, the specimen jar. So we remove the child's pampers or diapers, and we wash hands thoroughly before collecting the sample or wear gloves. So clean the skin around the genital area. Use clean plastic tweezers and gauze soaked in water if available, or use baby wipes. So keep watching until child urinates. we must be ready to catch a urine sample in the container when child starts urinating. So also to encourage child to urinate, we can gently rub their lower abdomen for a few minutes using a clean piece of gauze soaked in cold water. Hold the container away from the child's skin when catching the urine. Sorry. This is important so that bacteria from skin don't contaminate the urine sample. So next we have midstream specimen of urine. So this is suitable for older children. We can reduce the risk of contamination as the urine collected is only midstream urine. So first clean the genital area properly using gauze or sterile water, and then we collect the urine halfway through urination. First, pass the first part of the urine into the toilet, and then try to catch the middle stream with the container, and then finish voiding the rest into the toilet. Okay. Next, we have I will be presenting regarding peripheral intravenous cannulation. So indications include for blood sampling or also for intravenous fluid administration or for medications or blood components. Contraindication include we can insert it at extremities with broken bones or traumatic injuries, or any parts that has compartment syndrome, or if there is swelling or edema, or if the site we can insert it at the site of previous infiltrate of in the same extremity, and we must also avoid open wounds or broken skin. So equipments include glove, alcohol swab, tourniquet, topical anesthetic, 5% or ethyl chloride spray for rapid cannulation, catheter, heparin saline, a T connector, and rubber band for setting an IV line. So first, we must identify the vein for the vein puncture. So usually we target the dorsum of the.
Sorry. Can I ask? How many presenter do we have?
Six.
Six presenter, and you are presenting urinary collection and also what?
A peripheral cannulation.
Okay. All right, fine. Tak apa. Continue. Sorry.
Okay. Okay, so we identify the vein. Usually, most commonly we use the vein in the dorsum of the non-dominant hand, but we can also use find veins in other places such as a volar aspect of the forearm, dorsum of the foot, or great saphenous vein at the ankle. So secure the identified limb and apply tourniquet. So we can also use topical anesthetics, which we can apply with occlusive plaster, which means first we put the topical anesthetics first, and then we letak the plaster tu, and then we do this for hours earlier, so that this is for the anesthetics. Ataupun kita boleh ataupun or we can also do we can also spray with ethyl chloride for if it is a short procedure. So and then after that we clean the skin with alcohol swab, and we puncture the skin and advance the needle or catheter in the same direction as the vein at 15 to 30 degrees angle. So blood is collected once blood flows out from the needle. So and then the needle is then removed and pressure applied once sufficient blood is obtained. So this is only for if we only want to take blood sample. But if we want to set an intravenous line, the catheter is advanced a few millimeters further. Once blood appears, we withdraw the needle slightly while advancing at the same time advancing the catheter over the needle. After that, remove the tourniquet and flush the catheter with heparin saline. Secure the catheter and connect it to either rubber band or IV drape. And after that, immobilize the joint above and below the site of catheter insertion with restraining board and tape. So complications include accidental arterial cannulation, extravasation injury, or thrombophlebitis and infection. Next, we have peripheral arterial cannulation. So indications include when we have to do continuous blood pressure monitoring for the patient, or if we need to do a frequent lab sampling of arterial blood gas. Contraindications include if there is infection at the insertion site, or if there is traumatic injury proximal to the insertion site, or if there is inadequate collateral circulation of the extremity. So equipments include topical anesthetic, alcohol swab, appropriate needle with appropriate size, and also catheter size, heparinase saline, T connector, and heparinase saline for infusion. So first we must check for the ulnar collateral circulation by modified Allen test. So we carry out the modified Allen test, and after we have made sure that um, the circulation is suitable for cannulation, and we have also identified the appropriate pulse. Or if we can find if we find that the radial pulse is not suitable, we can also aim for other sites such as posterior tibial artery or dorsalis pedis artery. So and then clean the skin with alcohol swab and dorsiflex the wrist slightly. Puncture the skin and advance the catheter in the same direction as the radial artery at a 30 to 40 degrees angle. So the catheter is advanced 2 to 3 millimeters further when blood appears at the hub. And then we withdraw the needle while advancing the catheter. So we must ensure good flow and then flush gently with a small amount of heparinase saline. So we have to make sure that the peripheral artery is successfully cannulated. So how do we ensure this? We ensure that the arterial line is functioning by trying to find if there is obvious arterial pulsation in the tubing. So after that, we connect to the T connector and three-way stopcock to a syringe pump, and we label the arterial line and at the time of the setting. Label the arterial line. We also label the time. After that, we run the heparinase saline at an appropriate rate. For example, for neonates, it should be 0.5 to 1 ml per hour. So lastly, we immobilize the joint above and below the site of catheter insertion with restraining board and tape, just like in peripheral intravenous cannulation. And we must make sure not to make the tape too tight. Okay. So complications include there might be infection, trauma to the artery, or also thrombosis. Okay.
Any question from the others? Clear? What are the problems with mana presenter tadi? Presenter, apa nama?
Yes.
Okay, so let me ask you something. If you have a child who comes in your ward and then you think the child has the child, okay, I would say 6 month old, currently comes in with symptoms you think it is most likely is UTI, what would you send? How would you send? What type of method of urinary collection? Macam mana? Suryana? Mana presenter?
Yes. I think I will send for a suprapubic aspiration.
Why?
Jap. Uh, um,
Why? Then why are you looking? You presented, so you should know already the answer lebih kurang lah.
I found the answer just now, but I'm trying to look for it again.
No, you presented. There's nowhere else to look for. Why do you think is SPA?
because I think we need to avoid taking samples that comes out through the urethra because that is the site of the infection.
Okay, alright. So SPA is the gold standard lah. SPA, suprapubic aspiration, is the gold standard. But why is it not done commonly? It's not done commonly because first, not many doctors are actually trained to do it. Not many doctors have seen how to do it. And many people thinks that because you are using a needle, so it looks like it's traumatic. It looks macam very invasive. It looks very invasive. Sedangkan it's actually very easy, it's very safe. I think catheterization is much more painful and much more causing discomfort rather than SPA. But again, not many people are trained. My juniors, many of them have never even seen suprapubic aspiration. And then ideally we need to do with ultrasound, and many centers do not have ultrasound. So that's the problem, and it seems to be invasive. Okay, but otherwise it's the gold standard because it's the most clean method of urinary collection. What's the problem with catheterization? Sometimes catheterization you can cause injury, you can cause trauma, and then it becomes fibrosis, stenosis, and so on and so forth. So that's the problem. Okay, all right, fine. Next, proceed.
Okay, but before that, doctor, can I ask, do we do the SPA in our setting in the suspect?
Yes, not all the time. Sometimes.
Okay, thank you. Okay, so next, I will present it about gastric tubes. Next. Sorry, Anna. Okay, so for the outline, briefly, I will explain about the orogastric tubes, nasogastric tubes, and also gastrostomy. Okay, so for the first one is the orogastric tube, and also for the nasogastric tube. Next. Next. Okay, so what is orogastric and nasogastric tube? So as the name suggests, is a gastric tube, which is a tube passed into the stomach via the mouth and also the nose. And also for the I'm sorry. Currently, I'm seeing the indication slide. So, are all of you seeing the indication slide or the previous slide? So, takut kat sini dia jam sikit. So, lambat.
Sekarang orogastric and nasogastric.
Okay. Okay. So, what is the purpose of orogastric and nasogastric tube? So, basically, we want to give nutritional needs to the patient. The second one is we want to administer medication, we want to rehydrate them, and also for the purpose of decompression of the stomach. So as you can see, the picture of the orogastric tube. Okay, next. Okay, so what are the indication of orogastric or nasogastric tube? So basically, it can be divided into three. The first one is if there is any impaired swallowing or oral motor development or oral aversion, such as patient with cerebral palsy, neurologic problems, congenital anomalies of the GI tract, and also if the patient is premature. The second indication is if the patient has any impaired absorption or digestion, such as in patient with short bowel syndrome, cystic fibrosis, Crohn's disease, some inborn error metabolism, and also if the patient have any chronic renal insufficiency. And for the last indication, so we give the orogastric and nasogastric tube if the patient has excessive metabolic demands, such as if in infants, if they are presented with sepsis, congenital heart disease, or bronchopulmonary dysplasia. And if in children, it can be due to if they have any critical illness. Okay, next. Okay, so these are some of the contraindication of the orogastric and nasogastric tube. The first one, if there is any non-structural abnormality, For example, the choanal atresia, in which the nasal passage is not connected to the pharynx. The second one, if there any recent caustic ingestion. Caustic is if there is any corrosive ingestion taken by the patient. The third one is suspected spinal injury. The fourth one, if the patient have any known varices. The fifth one, if the patient have any stricture, trauma, and also if patient have any suspected of vessel of skull fractures. And last but not least, the last contraindication is it can be due to if the patient have any bleeding disorder. Okay, next. Okay, so for the preparation, so the first one is for the nasogastric tube size. So it can be divided. The first one, if we want to give feeding or decompression, and the second one is depends on the size, on the age of the patient lah. So if newborns, the feeding is 6 Fg, decompression 8 Fg. If the patient is infants and children below 5 years old, so feeding we give 8 and decompression is 8 to 10. And for the children above 5 years old, for the feeding we give 8 to 10, and for decompression we give 10 to 14. Okay, as for the positioning, so it can be divided into two. If the patient is an infant, so we will wrap the patient like shown in the picture. And if the patient is a child, so we will have the caregiver, a caretaker, to hold the child in the seated position, like in the picture. Okay, next. Okay, so for the procedure for insertion, okay, the first one is measurement. So we will measure using the tube from the tip of the nose to the bottom of the earlobe. And then we will proceed the measurement from the bottom of the earlobe to the observed midpoint between xiphoid process and the umbilicus, like shown in the third picture. Okay, next. Okay, so then we will lubricate the end of the tube after we have measured them. And then we will check one of the nostrils for the patency. And then we will gently insert into one of the nostril and advance the tube posteriorly, aiming the tube parallel to nasal septum and superior surface of hard palate. So, and then we will go into the esophagus and lastly into the gastric. Okay, so next we will advance until the measured marking is reached. Okay, and then we confirm the placement of the tube. And lastly, if the placement is confirmed, then we will secure the tube on the face with the tape, such as shown in the picture. Okay, next. Okay, for the confirming of placement, the first one we can check by using the tube length. So we will note the external length of the tube. So this is done using when we want to insert the tube in the first place. We will measure the total length of the tube, and then we can do a pH testing. So pH testing can be done by aspirate a small fluid from the NG tube, and then we will check the pH on the pH indicator. So basically, if the pH is less than 4.0, then we can determine that the tube is in the gastric. So it's correct placement, as the pH of the stomach is usually between 1 to 4. Okay, next. Okay, and lastly, we can confirm the placement by using an X-ray. So it said that usually the X-ray is done on a patient who is at risk infants and children, which are those who are on gastric acid pump inhibitors or on gastric pump continuous feeds, or patient with diminished or absent gait reflex, for example, children with developmental delay, neuromuscular disorders, and also bulimia. And last but not least, if the patient is with an altered level of consciousness. Okay, next. Okay, so these are the complications for the orogastric and nasogastric tube. So patient can be presented with apnea, bradycardia, or desaturation. There can be obstruction in the obligatory nasal airway. It can be misplacement in the initial insertion, such as misplaced into the trachea. The next can be displacement, coiling and clogging of tube, and last but not least, patient can develop infection. Okay, next. Okay, before we proceed, there's some additional note that I would like to add is uh, sometimes the doctors in the older patient we use a whoosh test. Whoosh test in which we will auscultate the abdomen of the patient to check if there is any presence of air kan bila kita push the syringe. However, in pediatric it is not a confirmatory test, so we should not do the whoosh test. And also, if the patient presented with absence of respiratory distress, we also cannot rule out whether the tube is not inserted into the trachea. Maksudnya walaupun patient tu tak ada respiratory punya symptoms, tak bermaksud kita tak salah letak. So the absolute way to confirm whether the tube is in the correct place is by doing X-ray lah basically. Okay, next the gastrostomy. Okay, next. Okay, so gastrostomy in which a surgical procedure in which we use to insert a gastric tube or G tube through the abdomen and into the stomach. So directly lah we use. Okay, next. Okay, so the types of G tube, it can be divided into two. The first one is non-low profile tube and low profile tube. So as you can see, the non-low profile tube is a bit longer, and low profile tube, it has no tube, basically no extended tube attached to it. Okay, next. Okay, so what are the differences between the types of non-low profile tube and also low profile tube? So for the non-low profile tube, is a long type of feeding tube that extend out of the stomach, as you can see in the first picture. While the low profile tube is a tube that sits close to the skin and easy to conceal. For the non-low profile tube, it has a disc that sits outside of the stomach. For the low profile tube, it can be referred as a button. And lastly, for the non-low profile tube, it can connect feeding bag and syringes directly into the tube. Whereas the low profile tube, it needs an extension set to connect to the tube for feeding. Okay, next. Okay, so as you can see in the non-low profile tube, the patient has a special bag in which she will use to conceal the extended tube. Whereas in the low profile tube, as it is just attached to the skin, so it doesn't need kata apa, nak cover sangat lah. Okay, next. Okay, so what are the indications for gastrostomy? So it can also be divided into three. The first one, if the patient has any inability to swallow or dysphagia, in which if the patient have any neurologic impairment, and also if the patient has any complex congenital malformation. Okay, the second one is the patient is failure to thrive or need supplemental feedings, such as in patient with anatomic intestinal abnormalities, functional intestinal dysmotility, and also if the patient has any malignancy. Okay, and last but not least, if the patient have any history of frequent aspiration, such as if the patient has any gastroesophageal reflux disease leading to pulmonary disease, and also if the patient has primary hypopharyngeal aspiration. Next. Okay, so for the types of gastrostomy, so basically it can be divided into three. The first one is percutaneous endoscopic gastrostomy, PEG. The second one is laparoscopic gastrostomy, and the last but not least is the open gastrostomy. But but I only will mention about the PEG. Okay, next. Okay, so as you can see in the picture, we can correct the PEG tube placement using the push technique, in which we will insert a tube endoscope with light, and then we will shine the light through the abdomen, and the light should be seen through the abdominal wall. And then what we'll do, we will palpate the abdomen, and if we can see the movement of the abdomen by using the endoscope, then we know that we are in the right place. Okay, so then what can we do? We can do a T fastener placement, and then we will insert a needle and guide wire insertion, dilator placement, and last but not least, we will put the gastrostomy tube in place. Next. Okay. What are the complications for the gastrostomy? So I divided it into three: intraoperative, early complication, and also late complication. For the intraoperative, the patient can have pneumoperitoneum, liver or spleen injury, hollow viscous injury, and also bleeding during the intraoperative. For the early complication, the patient can present with early tube dislodgement, abdominal pain, and also peritonitis. And for the late complication, the patient can be presented with dislodgement, catheter deterioration, tube occlusion, and also granulation tissue formation. So that's all for the gastric tube.
Any question? Any question from the group? Anything?
What is the difference between patient to indicated for low profile or non-low profile gastrostomy, or is it just the price difference?
Presenter.
In this case, I try to find the indication in which why we use these two. However, I can't find it. But due to my understanding, if you want to use the non-low profile or low profile, it depends on the patient and also the caretaker. In which, if the patient, based on the previous picture, we can see the non-low profile is a children more than 5 years old. Maybe the patient can want to go to school, so she need the non-low profile because she needs something that's to be attached directly to the skin, so that she needs the non-low profile tube, as the tube is complete, and then we can easily administer her food or medication by the tube. But that's from my understanding. However, I cannot find any indication lah, whether to use non-low profile or low profile.
Yeah, that's about it lah in terms of the reason. Sebenarnya low profile ni ke, it's easier lah sebenarnya untuk jaga. It doesn't look in terms of cosmetic pun it looks better. That's it. But the cost is a bit more. Okay, proceed.
So I will proceed with central line. So first central access, we have the root long line, which is peripherally inserted central catheter through jugular vein or femoral vein. Next. The indications for central line. The indications for central line include first, when there is a seriously ill ventilated
patient with typical peripheral vein access. And then the second one is emergency resuscitation, which requiring administration of large amount of fluids. Next is central venous pressure monitoring and placement of pulmonary artery catheter, also for frequent blood drawing and also longer term intravenous infusion compared to intraosseous access, such as for hyperalimentation, which is TPN, and then concentrated solution or vasoactive substances, and lastly for hemodialysis. Next is the contraindications, which can be divided into absolute and relative contraindications. So absolute contraindication for central line, severe abdominal trauma, which means that provided there is adequate venous access that can be obtained elsewhere. For relative contraindication, when there is absence of trained doctor for this procedure, and when a patient with distorted anatomy or landmark, bleeding and clotting disorders, and contraindicated when there is a skin lesion such as cellulitis, burns, abrasion or dermatitis. And then contraindicated when there is a condition that predisposes a patient to sclerosis or thrombosis such as vasculitis. And then the patient known to have a thrombus of the femoral vein for femoral central line. And there is risk of contamination of the cannula by urine or feces for femoral line cannulation. Next. So the equipments for central lines include all the sterile set for central line and the Seldinger cannulation set, including the syringe, needle, guide wire, and tissue dilator if the catheter is larger than 3F, and then 5 ml syringe and normal saline, T connector and three-way tap, analgesic lignocaine, skin preparation, chlorhexidine, and also sterile dressing. Next, is a video insertion of femoral central line. Maybe we can
Ada sound ke
proceed.
tak ada sound ni?
Ada.
Tak ada sound Okay, tak apa. It's okay. Kalau tak ada sound, dia kena describe lah.
So next. So these are the femoral vein cannulation. First, we need in any central line, we need to identify the landmark, anatomical landmark. So for femoral vein, kita akan first we need to palpate the femoral pulse, and then the femoral vein is located medially, and make sure the position of the leg is in a frog leg position with the hip externally rotated and abducted. Okay, when the femoral vein is identified, then we start the skin preparation and apply the Seldinger technique, in which first needle is punctured with ultrasound guided, and then advancing the guide wire through the needle, and then advancing infusion catheter, and lastly flushing the catheter to make sure that there is no resistance. Next. So these are the anatomic position for subclavian vein cannulation, which we need to place the position and position the child in a cradle lumbar position. And make a small incision at the junction of the medial and distal third of the clavicle. Insert the needle and direct it toward the posterior aspect of the sternal notch. Advance the needle along the inferior surface of the clavicle in a horizontal plane. And then blood will be easily aspirated when the needle enter the vein. So pass the guide wire through the needle and then remove the needle over the guide wire, pass the catheter and then remove the guide wire. Confirm that the blood can be aspirated from each part of the catheter and then flush it with normal saline and secure the catheter with suture and confirm tip placement. Next is internal jugular vein insertion. So there are a few route, which is anterior route, central route, and posterior route. Otherwise, the method is the same with other insertion of femoral of central line. Next. So in central venous catheterization, in one study, there is 1.3% overall rate of serious complication, which include of arterial puncture, malposition, hematoma, minor bleeding, and pneumothorax. So the most common one is arterial puncture. Next, pneumothorax is tend to occur on the left side because the cupula of the lung is higher on the left than the right side. And also catheter sepsis is common, either isolated or associated with thrombus formation, especially in immunocompromised children. Next, we move on to central access for neonates, which umbilical vein and also umbilical artery catheterization. So in umbilical cord, we can see there is a 2 artery and 1 vein. So first, the indication for uterine umbilical artery is for blood, for repeated blood sampling, and for umbilical vein, it's for resuscitation, mainly for resuscitation. So the equipment, first we need to have a sterile glove. For skin preparation is chlorhexidine. And then the forceps and mosquito forceps, scalpel, and then umbilical line, which size 5 French is a standard size, 3.5 French is in a very premature baby. And a size of 5 feeding tube can be used as a substitute. And then umbilical tape or suture, and then normal saline flush. Next, the technique. Can you play the video? Kak Su cuba unmute. Maybe we can move on. So the insertion of in the video we can see the insertion of umbilical arterial central line. From next, the step by step, we can see hold the umbilical stump up and clean it as with bactericidal chlorhexidine, and then place a loop of umbilical tape kat bawah tu kan, umbilical string, loose tight umbilical tape, and then cut the cord with a scalpel 1 centimeter from the skin and identify the vessel. So we can differentiate between the vein and the artery. At the next slide. So step 3 dah. Okay, step 4 next. So we can differentiate when we locate the umbilical vein, which is a thin wall, typically cephalic in the 12 o'clock position. And in newborn, it easily bleeds compared to artery, which is a thicker wall and less likely to bleed. For patient undergoing resuscitation outside of the delivery room, identify and remove any blood clot from the umbilical vein using a small or curved hemostat. Now, step 5, while holding the base of the umbilicus with the non-dominant hand, insert the pre-flush umbilical vein catheter into the vein, approximately 3 to 5 cm in a full-term infant, 2 to 4 cm in premature infant, and check for blood return. Next. So once blood return is confirmed, secure the catheter manually or with adhesive tape and administer medication, because in emergency umbilical vein catheter can frequently become misplaced during resuscitation. Check for blood return prior to each use. So the umbilical vein can be accessed up to only 2 weeks duration, 10 to 14 days exactly. Next. The slide already moving or not?
Dah, sekarang dekat
And lastly,
complications.
the complications. So lastly, the complications of umbilical artery or umbilical vein catheterization are air embolism, infection, thromboembolism. So we need to make sure the umbilical vein catheterization placed not too deeply, because it can dislodge the hepatic vessels, where medication may cause hepatocellular damage. Okay, I think that's all from central line access.
Any question? One thing, don't do subclavian for children.
Okay.
So we don't do subclavian for children.
Doctor, I have a question regarding NG tube. Okay, macam one of indication is for medication lah kan. Tapi kalau macam saya ada encounter satu patient ni, memang dia pakai NG tube even kat room, even after discharge pun dia pakai NG tube untuk makan ubat. So what is your opinion about this? Budak tu dalam 6 years old.
Presenter.
Soalan tadi regarding opinion sebab dia pakai lama ke macam mana? Sebab from my understanding, the NG tube usually we can use the duration is about 1 month lah before it need to be replaced. However, regarding indication nak pakai berapa lama tu, I need to know further detail lah regarding the patient.
Dia macam parents dia cakap macam anak dia tu tak nak makan ubat sebab ubat tu tak sedap, pahit kan. So tends to nak buang. So because of that macam parents dia tu macam decide nak maintain je NG tube tu. So macam, so what is the your opinion macam regarding this lah, kalau macam is it okay macam.
But the patient can kata tolerate orally kan? Macam mana?
Boleh. Tapi sebab ubat tu pahit, so dia tak nak.
I don't think that's the appropriate method.
Yeah, it's okay. It's
For
okay. We do have patients macam tu. If you see, I think few weeks ago we have one patient with nephrotic syndrome needing to eat prednisolone regularly. The child hasn't achieved remission for 4 weeks already. So I think in this sort of cases, sometimes bila not tolerating feeding, okay, it's okay for us to give the medication via rice tube. That's fine. Cumanya rice tube ni kita kena tukar regularly. Certain types of rice tube we need to change every 2 weeks. Certain types of rice tube we can keep for 1 month. There are some type of rice tube we can keep for 3 months. But generally we do need to change regularly. So that's the problem. That's why we don't usually keep rice tube for a very long time. Cuma itu kalau untuk ubat. Kalau untuk feeding pun we do have patient here in our NICU yang we have kept rice tube for 7 months. It's okay. You can continue rice tube forever, ever pun it's okay. Cumanya the more you continue rice tube, banyak isu. Satunya you won't train the sucking, swallowing. Yang keduanya is rice tube you can only pass through fluid sahaja, milk sahaja. You cannot pass through semi-solid. So that's the problem. We know by 6 months old, the child cannot grow well without weaning. Kan, milk saja tak cukup. Dia kena ada semi-solid and other types of nutrition. So that's the problem with rice tube. So that's why if you need feeding by tube feeding after 6 months old, you need to think whether should you continue with should you insert gastrostomy tak, which is more preferable lah. Gastrostomy you boleh bagi semi-solid. Okay, alright.
Okay, thank you.
Faham? Okay, I think we do need to stop here because I need to go and get my second dose vaccine. I was thinking kalau nak buat terus online sambil kat situ, but I think that will be a problem. The line over there is not that good. I think let's stop here. We'll arrange another session.
Okay, doktor. Doktor, but this week kita orang ada banyak masa yang free lah. So nanti saya bagi tahu doktor.
Okay, alright. Sorry lah for ada group pun ada banyak yang nak kena reschedule. There's just too many things. Okay, alright. Let's end our session with us.
Thank you, doktor.
Thank you, doktor.